Okay, thanks, Jeff. I think we'll have time for some questions in about 15 to 20 minutes, so if you can just hang on.
Okay, I'll mute myself.
Okay. So the next lecture was supposed to be given by Professor Bernie Zinman, who I think many of you know. Bernie's fine. Unfortunately, last Thursday after clinic, he tripped outside his office and the pavement won, and he broke a bunch of ribs and had some internal bleeding, and it was pretty banged up. And I just spoke to him about 12:30 today, and he's fine. He was actually in the hospital over the last few days, and he's probably going home tonight or tomorrow morning. That's what he tells me. And so he sends his regrets, and I am going to give his version of his talk. I have not added any of my slides out of respect for Bernie's vision for this lecture. So these are Bernie's disclosures, and this is okay. So obviously this lecture could have been extremely wide-ranging, and we could have talked about diabetes in pregnancy, or stem cells, or islet transplantation, pumps, genetics, etc., and this would have gone on for days. What Bernie wanted to do was really focus in on two areas that he has been intimately involved in at the University of Toronto, and we can come back to any of these other topics during the discussion. So we've had a nice series of lectures about the evolution and the history of diabetes, but many of you in the audience recall that even in the late 70s and early 80s, there were arguments about whether the complications of diabetes were genetically predetermined and went hand in hand with the development of diabetes, or somehow perhaps were brought on or exacerbated by poor glucose control. And this was a vigorous debate, and here are some of the long-term complications that have been challenging throughout the last 100 years. And the folks at the NIH, after receiving some requests for review from people that got together, put out an RFA that decided to fund this clinical trial that we all know is the Diabetes Control Complications Trial. And shown here are many of the original members. This was led by Oscar Crawford, and you can pick out, I think, Bernie Zinman right here. Bernie doesn't look that different these days, and you can probably pick out David Nathan and Saul Ganuth and many of the other pioneers. And they studied this question, the glucose hypothesis, really to say, if we have two groups of people in a randomized controlled trial and we keep one group with a lower glucose and the other group with a higher glucose standard of care, will there be any difference whatsoever on these clinical outcomes? And this trial went on for years until it was stopped, and you can see here there was no ambiguity whatsoever about the results of the trial, that people who had more intensive glucose control had a much different hemoglobin A1C that was much lower relative to the conventional group. And what was the result of that? Again, this was crystal clear. There were fewer diabetes complications, shown here either as the development of retinopathy or as I'll show you, many other outcomes. And this seminal study, I don't know how many of you were there in Las Vegas when this data was presented. This was one of the many standing ovations that I've been privileged to see at a diabetes meeting. And this paper, published in the New England Journal of Medicine, for those of you who are aspiring to acquire citations, is the single most highly cited paper in diabetes research, the original DCCT manuscript. So what did the group find? Intensive glucose control was associated with fewer rates of retinopathy, nephropathy, and neuropathy. All of the classic complications of diabetes developed at lower rates in people who were better controlled. And, you know, another question that came up is, well, what about heart disease. This was still a major problem. Most of us perhaps traditionally gravitate to thinking about heart disease as a complication of type 2 diabetes, because perhaps we're thinking of type 1 diabetes as commonly occurring in young children. But if one has the disease long enough, we do have higher rates of coronary artery disease in people with type 1 diabetes. And again, there were arguments about this. Was this simply the altered metabolism and more blood pressure problems and more cholesterol and dysregulated cellular metabolism, or could the glucose per se contribute to the increased rates of heart disease? And you may know that in type 2 diabetes, until very recently, this argument has continued because many of the studies designed to test the glucose hypothesis in type 2 diabetes, including originally the UK-PDS and VADT and others, really were ambiguous about whether glucose control itself lowered the rates of heart disease. And in fact, we had some studies, such as the ACCORD study for intensive insulin administration and glucose control, that actually showed more death in the insulin-treated group in type 2 diabetes. So what happened to coronary artery disease in the type 1 population? So you can see this took some time. So the reduction in rates of heart disease that we see with intensive control is not evident within the first 3 or 4 or 5 years, nor is it evident in people with type 2 diabetes, for example, in the UK-PDS. But over time, one can see a separation in the curves, better glucose control and lower A1C by itself, with all the other risk factors being treated aggressively in both groups. Simply having better glucose control is associated with lower rates of cardiovascular disease, either MACE composites or any of the individual components. Well, what about mortality? And many of you might think that's a silly question to ask, but in outcome studies, we often see, for example, reduction in one major category events, but that's offset by increased morbidity and mortality in another domain, which neutralizes the benefit. So we see this, for example, in the history of the development of obesity drugs, where we have weight loss offset by cancer or weight loss offset by high blood pressure. So one cannot automatically assume that this reduction in heart disease will translate to a benefit in mortality. But in fact, it does. And again, it's not apparent within the first 3 to 5 years, but if one has better glucose control over 5 to 10 years, we start to see a separation of the curves. And so not only are we seeing fewer complications of diabetes, and not only are we seeing less heart disease, but we're also seeing a reduction in the rates of mortality. So what does this mean in terms of the lives of people with type 1 diabetes? How low does one have to go? Where do we need to keep the hemoglobin A1C to see this benefit? And for mortality, which I'm showing you here, we can see that you can run a hemoglobin A1C, even between 7 and 8%, and still have a fairly normal rate of mortality compared to someone who has the same age who does not have type 1 diabetes. Now, of course, I would not encourage you to run your A1C of 8% because you will have more complications, but in terms of the overall rates of mortality, when it really starts to get into trouble, when perhaps one's in the 7.5 to 8 range, that's when the curve starts to move up. Now, there have been numerous developments in the formulation of insulin with rapid-acting analogs, with new basal analogs. Last week, Novo Nordisk presented the results of the first phase 3 trial for a once-weekly basal insulin. And for those of you who want to think about it, instead of having to give yourself 350 odd injections of insulin once a day as a basal insulin, it would be a lot easier to give yourself an injection of basal insulin once a week. And the hemoglobin A1C was identical compared to the conventional long-acting basal insulins, and there was no increased rates of hypoglycemia. So we continue to see innovation. Some view this as incremental. Others view this as important. And we have under development glucose-sensitive insulins. The concept there being that one could give yourself a dollop of insulin and it would only be activated and released from a depot when the glucose started to rise and when you need it. So we're going to see continued innovation in the development of insulin formulations, including, of course, in stem cells and artificial pancreases and other delivery devices. Now, the other therapeutic class that Bernie's been very involved in studying over the last, I'd say, 10 years or so are the Sglt2 inhibitors. And I think this represents, for me, a very important reminder that one cannot always predict the direction of scientific breakthroughs. Nobody 10 years ago would have predicted that these Sglt2 inhibitors, which simply block the ability of this protein to reabsorb glucose and therefore excrete increased glucose in the urine, I think there were very few papers that one could find that were written that said these are going to transform the management of diabetes. Yet, in fact, they have, because of their unpredicted ability to not only lower blood glucose, but also to reduce the rates of cardiovascular events, heart failure, and chronic kidney disease. The EMPA-REG outcome was the first Sglt2 inhibitor cardiovascular outcome trial to report. It also presented its results at a large meeting at the ESD. Bernie Zinman was the principal investigator. We had been through a series of disappointment after disappointment after disappointment where different glucose-lowering therapies or approaches to glucose lowering in people at risk for developing heart disease did not, in fact, reduce heart disease. And so the community was quite disillusioned at the time, yet we saw the results of the EMPA-REG outcome study, a 14% reduction in the primary outcome of 3-point MACE. That's major adverse cardiovascular events, non-fatal MI, non-fatal stroke, and cardiovascular death. And this was a very robust finding and driven by a reduction in heart failure. And notice the curves and when they start to separate, it's almost immediate. And so I just showed you some data for glucose control, which often for heart disease takes 6, 8, 10 years for the evidence to become clear that really good glucose control lowers the risk of heart disease. But look at the separation of the curves for Sglt2 inhibitors. It's really within weeks that we start to see a benefit for heart failure. We also see this very important reduction in death in the EMPA-REG outcome trial. This has been somewhat heterogeneous in some of the other Sglt2 inhibitor trials. There has not always been a reduction in death, but we certainly saw this in EMPA-REG outcome. And you can see there's no heterogeneity by subgroup. It doesn't matter whether you're male or female or older or younger or have longer duration of diabetes or shorter or have different degrees of blood pressure control. There's a consistent benefit of these medications. And once we started to see the results of the other trials with dapagliflozin and canagliflozin, this was clearly a consistent effect with all of the trials showing the same results. Now, these original trials, as you know, were done in people with type 2 diabetes. And the next set of trials asked the question, well, would we see benefits of the Sglt2 inhibitors, for example, in people with heart failure without diabetes, or people with kidney disease at risk for developing chronic kidney disease without type 2 diabetes? So could we repurpose drugs initially developed as glucose lowering, but could we repurpose them for general use in the heart failure population or in the at-risk for CKD population? And the answer we now know is absolutely we can, because we now have, again, multiple trials showing that heart failure and hospitalization for heart failure, and in some cases, as you can see, cardiovascular death is markedly reduced by these drugs, independent of whether or not individuals have type 2 diabetes or not. We see the same type of benefit for nephropathy, and this is now hard events, not just reduction in albumin excretion, but this is reduction in the rate of EGFR decline, transplantation, or need for dialysis, something that John Dirks spent a lot of his professional career looking at. And again, we see across the board, no matter what your starting EGFR is, and whether or not you do or do not have type 2 diabetes, there's a striking benefit of the use of Sglt2 inhibitors. Now, as a reminder, all of the people in this trial are already maximally treated with antiplatelet agents, with ACE or ARBs for their blood pressure, with statins for their cholesterol, and we're adding on top of maximal medical therapy, we're adding these new agents and still seeing a profound benefit. So we don't understand the mechanisms. This is something that is under active study. Sglt2 is a fascinating protein. It's largely localized to the kidney tubules. It's very little expressed in some of the tissues like the heart, where we see the profound benefit. So we still don't fully understand these mechanisms, but they are quite consistent both across the presence or absence of type 2 diabetes or not. And a big question in the field is, what about type 1 diabetes? We now have accepted these drugs in the field of type 2 diabetes, and the cardiologists and nephrologists, as they often do, adopt these drugs as their own and are quite comfortable now in prescribing them. But what about people with type 1 diabetes who also develop heart failure and coronary artery disease, and certainly chronic kidney disease? And this has been more challenging as a community. We had Sglt2 inhibitors approved in Europe for type 1 diabetes, but not in the United States or Canada. And unfortunately, companies such as AstraZeneca have withdrawn the marketing of dapagliflozin in Europe. And so we really need dedicated randomized controlled trials of these medications in people with type 1 diabetes. And of course, the concern is ketoacidosis, which is something to watch out for. So this is my whirlwind tour of Bernie Zinman's experience in the field. I think the DCCT EDIC trials and the Sglt2 inhibitor EMPA-REG outcome trials have really transformed the current management of diabetes. There's lots to say about the other classes of medications or technologies which I didn't mention, but in the interest of allowing John's meeting to close on time, we still have some time for discussion, and I'm happy to invite questions for either myself or Jeff Flyer that's still online, I presume. So on behalf of Bernie, thanks very much.
Thank you for your presentation. How important is the regular exercise, workouts, physical activity in preventing, managing, as well as treating diabetes or heart disease or high blood pressure? Can we consider the regular exercise as one of the best medicines that we already have?
Yeah, I don't think any of us would ever discourage a healthy diet and exercise and lifestyle. It's more difficult to do an outcome study that isolates the same magnitude of benefits with diet and exercise. In fact, the NIH, as you know, sponsored trials looking at lifestyle intervention with diet and exercise, and people lost about 6 to 8% of their body weight, but we did not see the same type of reduction in cardiovascular events. So we all believe that exercise is good for us and keeps us healthy, and perhaps will make us more youthful as we age, and we would never discourage it. But there is not a large randomized controlled trial that shows that diet and exercise, for example, can do the same types of things as we've seen with the new drugs over the last few years.
In the non-diabetic population that you gave the Sgl2 inhibitors to, because they're urinating out sugar, glucose, do they lose body weight? I mean, is that one of the underlying mechanisms, perhaps?
Very little, because as you know, the glycosuria depends on an elevated blood glucose. So if you don't have diabetes and your blood glucose is not elevated, the amount of glucosuria that you'll get is really trivial. So there might be a tiny little bit of weight loss, but not very much. If there's no other comments, I might invite John to give some closing remarks. Thanks very much, everyone. Thank you, Jeff.
Dan, thanks so much for filling in on short notice. You did a marvelous job. Well, this has been a wonderful day, and I thank all of you for coming and having such rapt attention for a full 7 hours, as it were, and hearing about, first of all, we paid tribute to Michael Bliss, who wrote the stories that we're still talking about and digging into. And then we had great talks by Ken McHardy and Allison Lee, James Wright, all about all the discoverers, what they did, the struggles, animosities, all those things, and honors that came by. And then Jeff Friedman took us in great detail, along with Kirsten Hall, into the whole pre-Toronto story, and we learned a lot on that. And it's so great that Erling Norby was giving us a real reflection of how the Nobel Prize works and how it related to the insulin honor in 1923, but also the outcomes that occurred and scientifically that related to insulin later. And that was also brought in by Jeff Flower just in his talk as well. And then Chris Reddy took us over the commercialization, how complex it was. And it was amazingly successful in such a short period of time, the connection with major companies like Nova and Lilly and so on. And Arlene Tuchman took us into another arena in terms of that diabetes is a public problem. It involves many kinds of peoples, ethnic groups, populations, indigenous peoples, races, the poor, the wealthy. And I think those are important issues in the social context to reflect on. And then we've looked at now the base of the discovery and how it had unraveled over the last 100 years, and a lot have happened. And isn't it interesting that even though immense progress has been made, and the situation is so much better and so many good outcomes, we've not answered all the questions, why the complications occur, and why we can't finally eliminate some of the critical aspects of diabetes from our human population. So the next 100 years have a lot of challenges in this area. And one of the challenges that I hope you'll join us for tomorrow is the McLeod workshop at the Campbell Conference just across from Massey Hall. And you're going to hear the ardent debates by Chris and Allison and Ken and James, focusing a bit on McLeod and to say what else should be done in our community to spread the honors retrospectively more evenly on the community. So I thank all the speakers, all the chairs, all of you for coming and listening. Some of us will have a nice dinner this evening, and tomorrow I hope that those of you who still have the endurance to come with us, we would welcome you with open arms. Thank you all.